So let's look at some value-based care definitions. To further assure semantic interoperability for our MOOC, let's look at the two most fundamental and important terms, value and value-based care. Value is a term that is widely used in many contexts, but generally is used in a consistent manner to encompass quality and cost. According to the Business Dictionary, value with respect to economics is the utility of a good or service. A perspective in the New England Journal of Medicine defines value as outcomes relative to costs, also observing cost reduction without regard to the outcomes achieved is dangerous and self-defeating, leading to false savings and potentially limiting effective care. Value is a term that is widely used in many contexts, but generally is used in a consistent manner, as we see here in these definitions, to encompass quality and cost. When you and I make any purchase, we consider value. And the classic example in most MBA programs anyway, that is used to explain this in lay terms is the value of buying a hot rotisserie chicken at a grocery store versus buying a raw chicken and cooking it ourselves. Grocery stores mark down the price of what it costs them to sell a rotisserie chicken because they use it as a loss leader. You buy the rotisserie chicken because even though it costs you more than buying a raw chicken and cooking it yourself, the smell makes you so hungry and reminds you of how quick and easy it is for you to buy. You are also likely then to buy the potato salad and whatever else makes a meal. The value to you and to the grocery store are clearly matters of weighing what is most important for each party. Value in healthcare then refers to achieving better outcomes and ultimately a healthier population in order to reduce the cost burden of healthcare overall. It is recognized, however, that we can't just lower costs by cutting services or paying less. The grocery store is not going to lower the cost of the rotisserie chicken unless it's pretty assured that it's going to enable the store to sell other things as well. But when we consider value-based care, we must recognize that there is more of a macroeconomic benefit, at least as seen by most general people, than a microeconomic benefit. A macroeconomic benefit is one that is for the entire country and will take time to achieve, where a microeconomic benefit accrues to an individual provider immediately. As a result, a program has been put into place that enables transitioning from our current fee-for-service payments to a value position. And that, of course, is value-based care. This is the term CMS is currently using to describe a program that is part of a larger quality strategy to reform how health care is delivered and paid for. CMS describes its value-based programs as rewarding healthcare providers with incentive payments for the quality of care they give to people with Medicare. These programs are part of a larger quality strategy, as I said, for how health care can be delivered and paid for so that we get better care for individuals, better health for populations, and lower costs. This three-part aim of better care for individuals, better health for populations, and ultimately lower costs for the federal government's Medicare and Medicaid programs is such that the federal government is betting that these programs will also be mimicked in the private sector. And indeed, most of the major health plans such as Aetna, United Healthcare, Blue Plans, and others are now offering such programs, sometimes using different names, but still focused on achieving better value. There's some other terms for value-based care commonly in use just the same. And these include terms like value-based contracting, value-based payment, value-based purchasing, value-based reimbursement. The New England Journal of Medicine perspective cited in the previous slide notes that value in healthcare remains largely unmeasured and misunderstood. Value should always be defined around the customer, and in a well-functioning healthcare system, the creation of value for patients should determine the rewards for all other actors in the system. Since value depends on results, not inputs, value is a central challenge. So the actors in healthcare value are individuals, patients, consumers, customers. We'll distinguish between these shortly, as well as providers, health plans, and funders, typically employers, though increasingly also individuals, who are paying an ever larger percent of the cost of care as co-payments, deductibles, and self-pay, such as in purchasing over-the-counter medications, care used at a retail clinic, care that is not covered by their insurer or any insurer. As the concept of value-based care has emerged, terms used by different actors have reflected their perspective. Unfortunately, until the term value-based care came into more common usage, especially from CMS, most of the terms focused on the cost side of value, as I mentioned before, and even more specifically, payment. In fact, some still use the term value-based reimbursement, even though the intent of the payment received under value-based care does not have a one-to-one relationship to a specific service. Terms we distinguish here must include contracting, payment, purchasing, and reimbursement, and probably we should also remind ourselves of the distinction between cost and price. Cost is the amount of money actually spent on providing goods or services. In healthcare, the cost of any given service, and sometimes we use the term unit cost, is very difficult to define, as the human factor certainly is highly variable, and there is also a high degree of variance in how providers practice medicine. Price is the amount of money for which a service is offered, and is usually some amount higher than the unit cost, even in a nonprofit setting where some money must legitimately be put aside essentially for a rainy day. It is because unit cost of healthcare services has been so difficult to define in healthcare that we rarely use the term price in healthcare. In almost all cases, providers are paid based on a contract with a health plan, or in a few cases directly with an individual or family, as in concierge medicine, wherein a provider, usually a physician, agrees to provide care for a fixed amount of money, often paid monthly. Contracting between providers and health plans is a much aligned process. Health plans use actuarial models to predict the level of health decline in the patient population served by the provider with whom they are negotiating a contract. Once risk is predicted by this process, health plans negotiate payment rates, often offering discounts, which are lower rates per person than predicted cost, assuming that the provider can use the fact that a contract with a health plan provides marketing value for the provider. It is noted that a similar actuarial and discounting process is used to set the price of premiums that employers can offer for their employees, with discounts offered for size and type of company, often reflecting risk of the work involved, and recently for offering wellness programs. So essentially, value-based contracting encompasses a discount not only for the value of marketing, but includes incentives to keep the population of persons healthier. Providers need good data about their population and their outcomes to be able to negotiate a good value-based contract for themselves. We're going to talk about this a little bit more in another lecture. Value-based payment, purchasing, and reimbursement are essentially spin-offs of value-based contracting. These terms reflect the amount a health plan pays a provider, sometimes called reimbursement for services billed, which is the term used in fee-for-service payments, and which may be less than what is actually billed, or what healthcare costs a purchaser, such as an employer, individual, or government in the case of Medicare and Medicaid. As noted, these terms were used initially to reflect the cost part of the value equation and distinguish from paying for volume, as in fee-for-service, to paying for value. Health plans are well aware of the lack of trust providers have in health plans, provider concerns for continued erosion of their incomes, and the fact that providers believe they know their patients best and how best to care for them. Providers, however, do value this notion of value in value-based care. They want to provide the best possible care. They also know that costs are skyrocketing. As such, both providers and health plans seem to have rallied around the concept of value-based, using any terminology, though appreciative of their reassurance that value-based care does focus on the care delivered.